The communication between what happens when a patient's in hospital and comes out is really important, because when patients are discharged, they regularly come to their practice within 24-48 hours of discharge wanting medication or to ask questions about what happened to them whilst they were in hospital. If we don't receive the discharge document with good information on it, we can't help the patient when they're discharged.
A good ED is one that tells us what medication has been changed when the patient's been in hospital, if anything's been started or stopped, and if there's any medication that's been started, how long is it to be taken for.
According to the standard NHS Hospitals contract, we should have discharge or clinic letter within 24 hours of admission, outpatient or day case surgery.
What we really need to know is what happened to the patient whilst they were in hospital. So did they have any procedures, what was the major diagnosis, and what happened to them. Another really important thing is the medication. So not just a list of medication they were discharged on, but why that's different from what they went in on. So a list of what they went in on, what they came out with, and then why they're different. That's really important.
What we don't want is having instructions that say please check user needs 2 days later. Now the EDD should be received within 24 hours of the patient being discharged, but sometimes if it's bank holiday or the weekend we might not get it. So if you say check user needs 2 days later, it might not be possible. So in those cases it's a good idea just to give the patient the actual form, and then the patient can go to the hospital if they can't get in with the surgery. Also bear in mind that some patients are housebound, so they're not going to be able to get to the surgery to have a blood test, and we would need to organise that. Also the blood test, sometimes practices only have a phlebotomist who will do home blood tests once a week, so it's not going to be done 2 days after hospital. So it's important to be aware of those kind of restrictions that we have in general practice.
Consultant to consultant or specialist to specialist referral is specifically laid out within the hospital standard contract as being something that should be done. Consultants should refer to their colleagues if it's relating to a condition that they're seeing the patient for.
Specialist to specialist referral, it is ideal for the hospital consultant to do it if it is for the same condition and he knows what is happening with it. If it is for a new condition, it is always better for the specialist to refer to the GP, because sometimes most of the conditions are dealt with in-house, so the referral can be avoided.
If the specialist has seen a patient for the same problem and it's something related, they can refer on with. For example, if orthopaedics sees a patient with joint pains and they think it's more of a rheumatology problem, they can refer directly to the rheumatologist in the hospital. It doesn't need to come back to the GP, who then has to basically just send the same letter to the rheumatologist.
With regards to sick note, if the hospital specialist is able to issue it, well and good. If they have any issues or problem, GPs will be quite happy to issue it as well.
When a patient has an episode of illness or a procedure in hospital, then it's appropriate that they have a fit note for the correct length given there and then.
The person seeing them in the hospital will often understand best why they can't work. If you've been seeing them in outpatients or as an inpatient, you'll understand better than the GP can how long they need to have off work. It's really important as well that the fit note is done for the whole time of their illness. So, for instance, if they've had a cholecystectomy and you think they need to have 6 weeks off work, don't give them just 2 weeks and then say, well, if you need more, go and see your GP. If you think they need 6 weeks off, give them 6 weeks off. As a GP, I might not really know the recovery period for certain conditions or certain procedures, so the specialist is in the best position to do that.
With regards to hospital results, it is best for the specialist to follow up so that they can respond accordingly. It becomes very difficult for the GPs as they may not know why the why the investigations were requested in the first place.
So when a patient has been in hospital or been to clinic and they want to query something with the specialist, often we find they come to general practice and they ask us the question. And as a GP, as someone who works in a general practice, that is very difficult for us to answer. They come to us, we have to then either ring the hospital or send an email or write a letter, and it can take days or weeks for that query to get answered. It would be much better for the patient if they had a contact in the hospital they could ring or email to get that question answered. Always the best way is face-to-face verbally, isn't it? But practically that never works. So allowing GPs and hospital consultants easy access to each other, I think, is really important, either by telephone or by email. I think that if a consultant wants to speak to a GP, I'd say all of my colleagues who work in general practice would say, if we got a message to say, can you ring Dr. X or Dr. Y, we just ring them back as soon as we can and try and speak to them. Or if we got an email, if a personal email is always better received than an anonymous letter, so it's always best to do that. We can then have a dialogue rather than it being bits of paper flying backwards and forwards. So email or telephone would be really good.